Good afternoon. Today's presentation, I'm highlighting the clinical results which I have seen, especially to those related with Parkinson's disease. I've been working in the field of stem cell therapy for the past 13 years and have treated more than 1,300 patients. It's a very different approach. It's a clinical approach, and I have to thank my esteemed colleagues who spoke before me and explained the science behind everything. This is also scientific and I'm only presenting the medical results. This slide lists some of the conditions that are being treated by us. These conditions include conditions like chronic spinal cord injuries, neurodegenerative disorders, cerebral palsy, diabetes mellitus, and many others. All of them are currently labeled as incurable and terminal. The cells that we transplant are prepared using a novel technology, and I would like to explain this very briefly. Conventionally, the embryonic stem cells are derived from the inner cell mass of a blastocyst, and the culture process usually involves the use of conditioned media, animal feeder cells, and other non-human products. And this creates problems in using them clinically. However, we do have some FDA-approved clinical trials which have just started. And we do see teratoma formations, chromosomal instability after 66 passages to 70 passages. Immunosuppressants are required, and because we do see antigen-antibody reactions. Our approach and methodology is slightly different. We have derived our embryonic stem cells from a single spare expendable pre-implantation stage fertilized ovum, which is donated, and it's duly stored. We have derived our cell lines from the 2 to 4 cell stage, and we have not used, as I said earlier, feeder layer or animal products. It's in suspension. There are two main cell lines, the neuronal and the non-neuronal, and we have been able to have a chromosomal stability for at least 4,000 passages, and we are able to give this cell line as a ready-to-use product. This slide just gives you an account of the milestones in our journey. We started in 1999. We conducted safety studies till 2002 in the lab, established treatment with a fixed dose and schedule and a protocol which is in place today. We have transplanted 1,300 patients, as I mentioned earlier, for over 13 years. And a patent for our technology is granted in 66 countries, including the US, Australia, New Zealand, Japan, Israel, etc. The evidence has been accepted and published in the Science and Regenerative Committee in the House of Lords in 2013. And we have publications in certain peer-reviewed journals, over 20 of them, and many more are under review process. In fact, the paper that I have written on Parkinson is under the review process. Just for the technology highlights, patented in-house cultured embryonic stem cell cultures from a single fertilized ovum. I would like to emphasize on this. This single fertilized ovum was taken in culture, taken after an IVF cycle in the year 2000. And since then, we've been maintaining that. It's non-contaminated, free from animal products. As I mentioned, it's karyotypically stable, viable, and it's a ready-to-use product form, suspended in normal saline, which is clinical grade. It is simple, cost-effective, and scalable with no immunosuppressants. It's very important for us clinically not to have any immunosuppressants, because if you are going to give those to the patients, as a clinician, I'm going to have problems. So I don't want that, and luckily we don't have to use that. And most importantly, not the least, it's that we have had no significant adverse events over 13 years of our therapeutic use. A quick background, I don't really need to tell this august gathering here about Parkinson, but clinically we know it's a progressive disease. It could be caused by a genetic, environmental, or without any reasons. Women have longer life expectancy. It affects a lot of people above 65 years of age. It has both motor and non-motor symptoms, and I'm going to go through this slide quickly. This I don't need here with such august scientists sitting here. But yes, the degeneration of the nigrostriatal neurons is due to multiple factors. And this allows the free radicals to damage the lipid membranes and the DNA from which we have these neuronal degenerations. Conventional treatments are there. It includes drugs and surgery, but there is no treatment that can actually cure or reverse the problems. We can maybe stabilize it. We can slow it down a bit. Stabilization also, I think, is really difficult. We do see slow progression. There are cell transplantation studies done elsewhere in which the embryonic stem cells derived dopaminic neurons have promoted certain partial recovery in Parkinson rat models, and they have shown neurons transplanted to 40 patients have shown clinical benefits only in the lower age group, and there are some more studies. We are the first to report the safe and effective transplantation in the use of Parkinson. Till now, we've treated around 30 patients with significant clinical improvements. I'm reporting one case presentation here. A 65-year-old male patient from the US, and he was seen by me in the year 2012, complaint of resting tremors, back and neck stiffness, bradykinesia, all the symptoms that we expect, and he was on anti-Parkinson medication. We got a SPECT scan done. I would like to spend some time here. A SPECT scan tells you the perfusion status of the brain. It will enable us as clinicians to see where the damage is and what the damage is, and how the brain is not getting oxygen, and that's how the symptoms are. So in this case, what happens is the gray colors are normal, the blue, the green, and the black. The black is absolutely non-perfused. And you can see this is what this patient's SPECT scan showed. But this was not enough, so we got a SPECT scan done, and you can see the scales here. Anything which was yellow and above in this scale was good, and anything below was hypoperfused. So we got the area affected with Parkinson's scanned. We had a treatment plan in place. We gave the treatment for around 12 weeks, and the intramuscular injections were given around for like 0.25 ml, and I repeated earlier that these cells are suspended in normal saline, and this was given twice daily. We normally give the intramuscular injections to prime the patient, and so that the immunogenicity does not occur. And then we also give IV for a little bit of a booster shot into the system, and we do have supplementary routes like the caudal, the epidural catheters, epidural space. We do not enter the brain because it's too invasive for us in a smaller setting, and we do approach and allow these cells to travel through the blood-brain barrier. And most importantly, we have discovered that nasal sprays, which we can give almost a minimum of twice a week, but even daily if required on the basis of the patient, we have seen good results. We did give him occupational therapy and physiotherapy, and these were the list of medications that he was on. And after therapy, he had a reduction in tremors, muscle rigidity, bradykinesia, balancing. His gait was good. He could take long strides. He had a reduction of pain and stiffness in the neck and a better ability to turn it around. This could be because of physiotherapy, and a reduction of numbness in his left hand and both his legs. And this was his SPECT scan after. What happened? Okay. Okay, sorry. Yeah, the same scan that we had seen earlier. After, we can see a lot of pinks and whites, and these were the quantitative analysis of how the scans have become better, because we have a report in which it says it is significantly improved. That is a greater than 60% change, and a before and after of the most relevant parts. Currently, he's off all medications. It's now 2015, so it's been 3 years. no medications, and he's taken treatment of a total of 3 months. He has a mild resting tremor in his right hand, which is the only persisting symptom, and that tremor actually gets worse when I talk to him about his Parkinson and things like that, so it's really intentional. He's back at work, he's having an improved quality of life, and we are all very pleased. I have also brought in data from my most recent Parkinson's disease patients, 9 of them out of the 30, because we're still in the process of doing it. So whatever we speak here is not really very conclusive. It just takes us towards a path or a way in which we could treat our Parkinson patients in the future. So we started, we used the UPDRS scales for before-end therapy. 7 of them showed improvement and their medications were halved. And this is in a span of 3 months. We have to continue with our assessments and see what happens, and maybe in the next conference I will be able to bring up this data. As already spoken earlier, the Unified Parkinson Disease Rating Scale, 0 is good and 4 is not good. So as we increase, it's actually worsening of the condition. This is before and after therapy. So all our patients are here, and you can see how they have basically improved. 2 of them did not show any change. This is for walking, and it's the similar. Again, 2 of them didn't show any change. Similarly, for postural stability, only 1 did not show any change. Tremor reduction was not seen. It was not seen in many, excepting 1. And the reduction of bradykinesia also was seen in 1 patient, but it is really important to also know that these stats have been generated after 3 months of therapy, and none of my patients have actually deteriorated in those 3 months or increased their medications. And the medications actually halved. So that could be another reason which we need to follow up and understand while we work in the clinics. And because this is a movement disorder clinic, I thought it would be interesting to show our patient on spinocerebellar ataxia, and this paper, the case series, has been published. And this is a 59-year-old male doctor with complaints of difficulty in speech and sleep, maintaining balance, writing, walking, memory loss, and he's actually stopped his practice. He couldn't write. He couldn't think properly. So we got his scans done. This was not a quantitative, this was a quantitative, not a qualitative scan. And again, the colors yellow is good, but it has to be whiter. So after treatment, he became better. His speech and everything became better, and actually he went back to practice, though on a wheelchair, though he could walk a few steps, maybe from here to where you are sitting. And he used the wheelchair, but he could walk and he could talk, so he could go back to practice. And that's his scan. He still has the cerebellar symptoms. And the comparative scans, you can see clearly, just a summary, that it's a very safe, embryonic stem cells is a very safe and effective tool in treating our patients with Parkinson. There are no adverse events or teratoma formations seen in our patients. The international scores have been done, and they have shown that patients have improved. And I want to emphasize here that our clinics and our staff is really very well geared to noting any adverse events, and we note everything. Supposing a patient, like even right down to a URI or a UTI or even Delhi belly, but we note everything, and we have seen no adverse events, no serious adverse events, which couldn't get taken care of with medical practice, medicines and things like that. And embryonic stem cells could be the potential therapeutic agent in the future. And I would just like to, these are our publications, and thank you.
Thank you so much.
Thank you.
Seems to be a very interesting development in the Parkinson field. And of course, there will be quite some questions I would have added. Please.
So the question for you is this: you said that we have embryonic stem cells.
Yes, yes.
How do you know that those are stem cells?
We have all our markers and all these studies which have to be done. All the embryonic stem cell markers like OCT and NANONG and SOX and you can name it, we have that. In fact, our scientific paper was also published, which you could go through, which we have talked about our neuronal cell line. I think I can send you the link if you would like to. So we have all the data there.
Can you show the picture of where the corticosteroids like, they do differentiate or not in culture?
Okay, so how I differ, number one is the source, number two is the technology of not using any animal products, but more importantly, what we do is we actually nudge them towards a neuronal and a non-neuronal, so it's a precursor cell, and the neuronal cells, we do not allow it to differentiate fully into an astrocyte, oligodendrocyte, or whatever else. We have the precursor cell line with us. We transplant them after doing all the various tests that are required. And when they, because of their quality of homing in and actually being able to differentiate into the required neuron at the space that is required, we have been able to get the clinical response.
When we inoculate them, they are differentiated or not?
Not fully, they are precursors. If you call that differentiated, yes.
In what way?
We give injections through intramuscular, intravenous, as well as at the base of the spine through the epidural space, caudal space. And this size, we have done the electron microscopy of the images of these cells, and they're very small. They're less than 1 micron, which is very interesting. And then these microns are able to go through the blood-brain barrier, and it's just fascinating. So our paper is published. You should read that.
Yeah, it's possible, but it's hard to believe.
Yes, I know. I know.
Because those are the stem cells, a very tricky business.
Yes.
The stem cells, you don't know where they go. Do they go to replace something or where they become functional or not functional?
See, for me, okay, let me, because I'm a clinician's scientist, so as to say. So as a clinician, for me to know that these are my MRI, SPECT scans, clinical examinations, the international scaling, and I have improvements, so I'm really pleased, and the patient is good. But on the other hand, when I'm talking as a scientist, then for me to, have literature behind me in which the homing inabilities are there, in which, they have injected dog, say for example, with a cardiac cell, and they have found that the cardiac cells are all found in the heart 24 hours later. I'll tell you the name of the paper if I recollect it. So for me as a scientist, to know that I am transplanting a totally, in my mind, it's a minimally manipulated cell, which is a human product, which is actually showing me neurons. Actually, that's another paper which it's on review. So yes, that's what I was. No, I could not do that because I work with human beings. I'm sorry about that. But yes, that's a good question. Yes.
Okay, well, that's great. Excellent presentation. I wish the results could be the beginning of the good news for Parkinson's patients. But my comment is on the MDS website, the MDS Society, the International Parkinson's Disease and Movement Disorder Society. Their evidence-based guidelines at the moment say that there is no evidence for what you just said. So what will be your comment to that?
My comment is that it's a new field. We are publishing, and I'm presenting. So soon they will accept it.
My question is for this patient who did not respond,
Yes.
as well as the good patients. Do you have an idea why this patient did not respond? This is a difference in the preparation of these cells, for example, like those who responded get better
Sure.
preparation
Mm-hmm.
or not? So then we can go, or we know at least why those responded, and then we can be more selective. By the way, I'm a dermatologist and not I'm just coming here just pitching because my father has Parkinson's disease. So I'm looking for a treatment for my father. So it's not my interest. It's my interest in dermatology. So good that I have attended this lecture. So I'm happy to find out any light advice.
Okay. So to answer your question, the first patient actually has a long-term follow-up. Remember, I saw him in 2012, and today it's 2015, and I'm talking about his latest position. So these cells need time to grow. And, it's not as if I'm injecting it and it's going to be magic, which is what I showed with the 9 latest, most recent patients. They had only a 3-month follow-up, and now I need them to come back to me and be in touch, and then come back with that data a little later.
There are so many questions that we don't have no time to.
That's why I kept my presentation short.
I think a principal question, because this is really a very important issue. But before coming to clinical trials, it is obviously that you should go via the preclinical studies.
Go.
Via preclinical studies, it
Ah.
means, well, that was made, for instance, in Parkinson's disease, that was in 90 by Björklund in the European program, by Ormanov in the United States, and this is actually a necessary condition because you have more opportunities to identify cells, to look what happened with these cells, etc., etc. Are there any preclinical studies?
I understand your question, and I started my cell therapies in the year 2002 with a safety and clinical efficacy with an institutional ethics committee on board, and they gave me directions as to, because there were a lot of scientists along with other people. So they said that at that point of time that because it's a purely human product, and because they gave me clearance to use it on incurable and terminal conditions according to the guidelines in our land. So they did not say anything about the preclinical, and as a doctor, I felt that the preclinical was not important considering myself, but yes, I understand where your thoughts come from, and I respect that.
Any more questions, please?
Yeah, I have a question regarding different patients. You showed in the graphs that the scores for some patients changed and for some others they
Yeah.
didn't change. But did you check the different pharmaceutical treatment? Because the first patient you showed, I only had a quick look and I've seen he was treated with Cymbalta.
Yes.
And all these drugs concerning the CNS have different functions on the different neurotransmitters. Maybe you should check between the different patients if there is some beneficial effects.
Yes, I agree with you, and the reason why I didn't show the medications, etc., because I wanted to give time for the question-answer sessions. We have all our patients on Syndopa, and we do have a lot of their supports like Ropark and things like that. I don't, in my experience, which is now not really very, because I'm not a neurologist, so in my experience, these medications haven't really affected my response in the cell therapy. It's only the time frame, which is at the moment, is what I can comment upon. But yes, I agree with you, and I will look into it. Let me see what happens. Thank you for the suggestion.
Thank you for the talk. It's very interesting, especially with the, knowing that there are many cures or many treatments. It's really a good thing to have. My question for you is, I know you have a lot of functional imaging like specs.
Yes.
Do you have any of the actual like MRI or CT? Because the stem cell is supposed to
Yes.
be propagating to the
Yes.
dopaminergic neurons that we want them to. So is there any CT or MRI scans showing the increase in
Yes, see, we got the MRIs done for all our patients before. The person who has to get his MRI, the one that I've spoken about, the 65-year-old, is going to get the MRI done now this year when he comes back to the clinic. So the after I could not show, so I'm not commenting on that as yet. But definitely the MRIs, the PRODATs, the SPECT scans, and I wish even serum dopamines could be done, but that we are finding a problem in doing. So yes, and also with so many experts here, if we know what we need to do to really establish this as a field, we are willing to do all the tests because, it's good to have all the brains put together. So thank you.
Yes, please. I was wondering how long have these patients been followed? Does it include the period post-movement period when cognitive disorders might set in? Has it been followed that long to see whether or not you avoid that as well as the movement problem?
3 years is what I followed up, which I've submitted to you. The recent patients I can't comment on. However, having said that, this is only for Parkinson. Having said that, the first patients that I transplanted in the year 2002 for various other conditions are still under follow-up. And 3 years, I don't think is good enough. We have to wait for a little longer.
Brilliant talk. One quick question. 9 patients, how different will be in terms of the severity of Parkinson's disease?
Okay, so one of the patients was not too bad. The rest of them were actually worse than the 65-year-old gentleman that I spoke to you about. And they all had support while walking because, you know, they couldn't get up, they were frozen, they had shuffling gait, and yeah, their scores were different. It's difficult, yeah. But then I had to bring out what I have, yes.
Well, I just have some, very few questions to get to do. But one question is, of course, you know this, of course, best. So it is, you wonder about, and perhaps you know there is a literature on this, how, or in modern animal models, how can these embryonic stem cells penetrate into the CNS? I mean, we all know about the blood-brain barrier, but there are also special barriers, let's say, like in the subphonical organ, where you may have a special penetration possibility, I mean, just as a speculation, to get them into the CSF and then to travel in the flow of CSF and then into the Geeta-Shroff spaces and down into the extracellular space. I would like to hear your comments and ideas about this.
Okay, so in Parkinson, what we also thought that we would do the intrathecal route so that it would go straight up and into the CSF and into the CNS. We had done it on a few patients, but these 9 patients, I have not done that. Okay, so yes, I agree that that could be one major route. I don't believe in going invasive and injecting directly into the brain because, I mean, not because of anything else, but because it is so invasive and you really want the Parkinson patient who's already so weak, you know, not to have a deterioration in his health because of a procedure. But having said that, that could be considered later. It's a very, very early stage in the embryonic stem cell world. And as far as my cells are, what I found was that their size, homing in quality, and of course I need to do a lot more work on this, is the reason why they have gone through the blood-brain barrier. They've been able to transverse into it and through it go to the brain. Because day before yesterday I spoke on cerebral palsy. And cerebral palsy children, we have found a huge improvement and in a matter of 2 months and permanent improvements. And the reason is this, and we've only given intramuscular intravenous. We don't even go through the other routes which we do in Parkinson, like nasal sprays, you know, using the olfactory nerves to go directly to the brain. So yeah, there are certain questions and certain things that do come to your mind. And as I've already said, I mean, more brains, the better.
Yes, I think that would be very interesting
Yes.
data coming up then.
Yes.
Since as far as I know about the immune cells, they do travel over the subcortical organ
Yes.
to reach into the CNS
Yeah.
states. And look forward to these findings. The last comment is something that perhaps all of us are wondering about. Is there a possibility of some sort of proper control?
Yes.
I know it's tough.
Yeah, it's tough.
Control, but
Yeah.
everybody is waiting for the control injections, of course, one way or the other.
See, for me as a clinician, practicing, and with the ethics committees telling me so, that it is not okay to say no to a patient who is suffering, I cannot do that. However, having said that, if someone wants to do that, I'm happy. I'm willing to.
Well, we are looking forward to the future.
Thank you. Thank you very much. Thank you very much.